Today we will talk about odontogenic cysts and the management of the cysts. Now, as an outline, we will talk about the cysts. We will talk about how to diagnose them, how classification, the management, and the common cysts that we can see in the oral cavity. Now, what is a cyst? It's a cavity. It is a pathological cavity. It has fluid or semi-fluid content. So a cyst, it's a pathological cavity. It's not supposed to be there. It has a fluid or semi-fluid material with epithelial lining. They're more common in the jaws than any other place, and usually some cysts have epithelial lining, some cysts do not have epithelial lining. Now, to call it a cyst, there are some key features of it. As I said, it should be a pathological cavity. Now, they're usually asymptomatic unless they're secondarily infected. So the patient can have a cyst for like 2 or 3 or 4 years or more, but there are no symptoms whatsoever because there's no infection in it. But once there's an infection, they become symptomatic. They expand slowly, rarely cause fractures, but some cysts can cause fractures. Displacing and loosening of the teeth can be happening. Resorption is not common with them. So there will be no resorption in most of the cysts. There will not be resorption. We will see more displacement, more loosening. The teeth would be loose and more towards displacing the tooth, either labially, lingually, mesially, distally, whatever it is. On the radiograph, we will find that it's a well-defined radiolucent cavity. Well-defined cavity with smooth borders surrounding it. So signs and symptoms can range from none, swelling, intraoral discharge pain, denture difficulties, looseness of teeth, eggshell cracking of the bone, paresthesia, and pathological fractures. Now, to diagnose a cyst, first we will need the history and examination. We inspect for any swelling, looking at the patient. Inspection for any swelling, looking at it if there is any apparent swelling in the patient, palpation for the eggshell cracking for the fluid content, percussion, and auscultation. Now, auscultation cannot be done in the oral cavity, so we replace it with aspiration, placing a needle and aspirating from this cyst. Now, to diagnose a cyst as well, we need vitality testing. To check if this tooth is vital, non-vital, to know the type. Is it radicular or is it non-radicular cyst, dentigerous or keratocyst, whatever the causes. Imaging, panoramic X-ray or CBCT if we want to see the 3D cystic lining. And we take a biopsy sometimes from the lining to see the type of the cyst and the albumin level if it's less than 4 or more than 4. Now, we have two types of cysts that we will talk about, inflammatory or developmental. If it's inflammatory, the albumin will be low. In inflammatory conditions, the albumin would be low. In developmental keratocyst or whatever it is, it will be higher than 4. Now, sometimes the fluid that we aspirate can tell us the type of the cyst. If it's cheesy material, creamy white, cheesy material, usually it's most likely keratocyst. If it's clear, pale, straw-colored fluid like apple juice, dentigerous cyst. If it's yellowish, pus inside, it's infected. If it's blood, either we inserted the needle into a blood vessel or it's a vascular lesion. Now, how to know the fast flow? Usually in vascular lesions, there will be very fast flow in the cyst, in the aspiration. If it's needed in a blood vessel, also it would be fast, but not as fast as the vascular lesions. Either we're in the maxillary sinus or a traumatic bone cyst. So To summarize the types of cysts, we will talk about them later. Odontogenic or non-odontogenic cysts. The odontogenic are 90% of all the cysts. They can be developmental or inflammatory. The inflammatory is more common. Radicular cyst is the most common cyst that we can see. The developmental, we have odontogenic keratocyst, dentigerous, eruption, lateral periodontal, and so on. For the non-odontogenic, they can be epithelial lined or non-epithelial lined. Epithelial lined like nasopalatine, nasolabial, medium palatine, medium mandibular cyst, globulomaxillary cyst. The non-epithelial axillary bone cyst, aneurysmal or Staphylos bone defect. Now, as a management, we have two major options: marsupialization or inculation. Marsupialization means that we decompress the lesion. We do decompression. We open an incision. We suture the lining of the cyst with the mucosa and keep it open while placing a tube inside to drain the cyst. This is marsupialization or decompression. We reduce the amount of fluid in the cyst. Now, cysts enlarge because of the hydraulic pressure theory. The amount of fluid inside the cyst is very high. Now, the space that they have is very minimal, so either they blow up or form sinus tract, or they enlarge. They start to absorb the surrounding bone and enlarge. That's how it goes up. So, marsupialization, we bring an area of low pressure and opening for the fluid to go out, which would reduce the size of the cyst. Now, in inculation, we remove the whole pathological cyst, all of it, we remove it. Now, we can use it with curettage, peripheral osteectomy, removal of bone surrounding it, carnoid solution, bone grafting, marsupialization followed by inculation, or resection. So these are the management protocols that we can use for any cyst. Now, marsupialization, as we said, it's decompression. Now, usually there are some disadvantages for it, that we let the patient go with pathological tissue remaining. That's kind of a disadvantage, because the patient will have the pathological tissue still there. The patient needs very good compliance. We need a very compliant patient for the procedure to succeed. If the patient is not compliant, if it gets infected, if he doesn't clean it properly, he needs to have a cleaning every day, twice a day, or 3 times a day, whenever he eats sometimes. We need to keep cleaning it with normal saline. So if the patient is not compliant, we don't go for it. But there are some indications for it. Marsupialization, I can use it in cases where I have dentigerous cyst and I want to preserve the canine or the wisdom. If I want to preserve the tooth, if I want to preserve a vital structure, I will do marsupialization. For example, if it's close to the inferior border of the mandible, if I do inculation, I will cause fracture. No, I will go for marsupialization. If I have close to the maxillary sinus, if I have it close to the ID canal, if I have it close to the mental nerve, all of those, I wouldn't go for marsupialization. If the patient has poor medical health, he's not fit to go for inculation, also I would need to go for marsupialization. Now, easy, simple, safe, can be done by anyone, but high dependence on compliance and leaving pathological tissues. So what we do basically is that for example, we have here this cyst and I want to preserve the 5. So I aspirated its bloody content, I guess. This is a case from our book, actually. Now, the extraction of the tooth helped to reduce the amount of fluid and formed a path for the cyst for the fluid to go out. And as we can see, the sutured opening, the lining is sutured to the mucosa to keep it open. And here we can see the tooth erupting. Here another cyst, a keratocyst. They did marsupialization The tooth was extracted, and to prevent pathological fracture, they extracted the wisdom tooth. They kept it open until the cyst fluid cleared, and then it closed, and there's bone regeneration in the area. So, inculation, we remove the whole cyst. Now, it's the treatment of choice for any cyst. So, if I can do it, I prefer to do it for any cyst that I have. I extract the tooth, for example, if it's related to a tooth, and then I remove the cyst. Now, after inculation, we can go with the curette and remove the burr, and remove 1 to 2 millimeter of bone around the peripheries. Usually, we do it in most of the cysts, but the indications in the odontogenic keratocyst or recurrent cysts, or large cysts, for example. Now, it decreases the likelihood of recurrence, but we remove a lot of bone surrounding it, so it's aggressive management. So here's one of the cases I had. Here we had a cyst in the maxilla in the left side related to the C, D, and E. I did a vestibular incision. I removed the amount of bone. It was eggshell cracking, so I just placed the blade and the bone cracked itself. Now we remove the whole cyst and did suturing with the extraction. Here is another case, a radicular cyst related to the lower 6 roots, pressuring the ID nerve. We extracted the 6 and we did inculation for the lesion with observation of the ID nerve. In odontogenic keratocysts, sometimes we need to use carnoid solution. Now, it has 100% ethanol, chloroform, lactic acetic acid in 6:3:1 ratio with added ferric chloride 1 gram. Now, it penetrates into bone up to depth of 1.54 millimeters after 3 to 5 minutes of application. It's odontogenic keratocyst, as we said, that's where we use it most of the time, but it's neurotoxic. If I have closed nerve around me, I prefer not to use carnoid solution. Bone grafting, it's not recommended if I'm not sure that I remove the whole cyst. If I use an autogenous bone, it will increase the morbidity. If synthetic bone was used, it will delay healing. Now, as we said, if I have a risk of fracture, I can use marsupialization. Once the cyst is smaller in size, then I can inculate it with no risk to peripheral or vital tissues. I will go for inculation. Now, resection, we have 2 types mainly. Segmental, in which we remove a segment, or marginal. Now, marginal, I remove a margin. We have 2 types, segmental and marginal. Now, in segmental, we leave the inferior border of the mandible as itself. So we do not involve the inferior border of the mandible. In segmental, we involve the inferior border of the mandible. Now, if we take more, we call it hemimandibulectomy, removal of half of the mandible. Now we'll talk about common clinical cysts. As we can see, we talked about this classification in the beginning. Now, the most common cyst in the oral cavity is radicular cyst. It's usually associated with an infected tooth, with a necrotic tooth. It can be apical at the apex, lateral due to lateral canals, or residual, meaning remnant after an extracted tooth. usually non-vital tooth, and the apical radiolucency would be very similar to periapical granuloma, just larger. It can be without any symptoms. Now, depending on the tooth structure itself, it decides the management. For example, in cases like these, we have root caries and the tooth is non-restorable, we go for extraction with loss of bone support, extraction and inculation. Here, we'd go for endo treatment. Here, inculation alone. Here, apicectomy. So, we can go for extraction and inculation, inculation alone, RCT, endosurgery, inculation of the cyst, and apicectomy. So these are the treatment options that we have for radicular cysts. Now, the developmental cyst that we see a lot is the dentigerous cyst, usually associated with an impacted tooth. Now, what's the most common tooth to be impacted? It's the wisdom tooth. So, the most common tooth to be associated with a dentigerous cyst is the wisdom tooth, then the canine. It can be central, around the crown, laterally around the crown, or circumferential, surrounding the whole tooth. If we find multiple dentigerous cysts, this will let us to a differential diagnosis including Gardner's syndrome. Now, the management usually inculation and curettage or marsupialization if you want to save the tooth. Now, keratocyst, it's the more aggressive, higher rate of recurrence. They found out sometimes they called it a tumor, odontogenic keratocystic tumor. But then they went back into a cyst because they found that its aggressiveness and its growth is not similar to a tumor. It has anterior-posterior growth, meaning the buccal and lingual plates would remain the same, but it will go anteriorly and posteriorly. Usually in the posterior mandible, the recurrence rate is up to 62%, and it has a high risk of association with basal cell nevus carcinoma, or nevoid basal cell carcinoma. Now, in basal cell nevus carcinoma, usually we will have multiple basal cell carcinomas, epidermal cyst of the skin, odontogenic keratocysts, palmar plantar pits, calcified falx cerebri, rib abnormalities, bifid ribs, spina bifida, and so on. Now, the more important is the medulloblastoma. It's very risky, and if it's present, it causes a very high risk for the patient. Now, treatment goes from inculation, marsupialization, then inculation to resection. Because it's more aggressive, and sometimes we can use carnoid solution. So here's a case of odontogenic keratocyst, and that's the bony window after it was inculated. Now, glandular odontogenic tumor, usually it's aggressive and more to the anterior portions of the jaws. Less recurrence rate than keratocyst. Now, differential diagnosis can include ameloblastoma. It can include radicular cysts if it's small, central giant cell granuloma. Now, the management is inculation. For lateral periodontal cyst, to differentiate it from apical or radicular cyst, usually it's a vital tooth and asymptomatic. Now, the more aggressive form of it is called botryoid, which looks like grape. Now, the nasopalatine duct cyst. It's a palatal cyst between the roots of the central, heart-shaped, about 7 millimeter radiolucency. Now, that's how we differentiate it from the nasopalatine duct itself. It's larger, more radiolucent, and it's the most common non-odontogenic cyst. The treatment is inculation. The globulomaxillary cyst, that's an umbrella term, cyst between the lateral incisor and the canine. Usually, inculation is the management for them. The medium mandibular, similar thing, odontogenic in origin, ankylation is the management. Now, nasolabial cyst is a soft tissue cyst with unknown etiology, more in females between the fourth to sixth decade and fifth decades of life. Usually, there will be swelling in the nasal fold, local resorption of the maxilla, can be lined with squamous or respiratory epithelium, and inhalation or excision is the management of choice. Now, sometimes we might need to go for an ultrasound because it's a soft tissue lesion. Ultrasound helps us to recognize soft tissue lesions. Now, sometimes also to assess if it's vascular or not. Aneurysmal bone cysts, it's a giant cell lesion. Hemorrhage is very aggressive in these cases. Very hemorrhagic. Now, it has a well circumscribed soap bubble type radiolucency. Recurrence is rare. Solitary bone cysts, usually traumatic, asymptomatic, sometimes biopsy or aspiration is curative for it. More in the posterior mandible. Staphy's bone defect, it's salivary gland depression, usually in the mandible below the ID canal, mostly bilateral, and it contains ectopic salivary tissue in continuity with the submandibular gland. So this is the lecture of cysts. Now the take-home messages: always take an X-ray to see if there is a cyst underneath the tooth you're going to extract, and if suspicious, refer. If not suspicious, take a biopsy. You never know when you find a cyst that is actually an ameloblastoma. You never find out. Always do aspiration. If you open on a bloody vascular lesion, it's very risky and it's very bad, and you will need a lot of control to control the bleeding. So always aspirate before you start doing any procedure so you can know if it's vascular or not. And thank you. I hope you enjoyed the lecture, and any questions, I'm always available.